Hello, everyone. Welcome back to the Dean's Chat Learning Series, a new initiative that Dr. Jensen Richey and I have taken on. And our guest today is our resident infectious disease expert coming on Dean's Chat version of Dean's Chat for, I think it's the fourth time, Warren.
Something like that, yeah.
I think so. You've got stock in this Dean's Chat mug company.
Well, yeah, absolutely. And that's why I'm getting ready to go into retirement from all the proceeds from the stock from the mugs.
All right, sounds good. Well, this is so fun because
Just get me a mug. I don't care about the stock. I just want another one.
I was just teasing you. We'll get you two if you want.
An insulated one next time.
Oh, yeah, Warren, I think it'll be a Yeti cup or something.
Well, you know what? That to me would make it all worthwhile. Coming on and spending time with you guys. If you actually change your Dean's Chat mugs to a Dean's Chat Yeti tumbler, I'm there. You just call me whenever.
So maybe, Joe, we have to make it a VIP mug for people that are on multiple times or something.
Well, I think being the fourth return, I think you're the most frequent flyer miles. So I think that's fair. That's earned some insulated mug.
I'm honored. With you guys having already accomplished over 300 of these, I'm honored to be a frequent flyer. Thank you.
You're more than 1%.
Yay.
There you go. Well, so Warren, in all seriousness, one of the reasons we started the Dean's Chat Learning Series was really to delve into different areas of medicine within the podiatric field, whether it's medicine and surgery, so that we can increase knowledge base of our listeners. Most of them are DPMs, but also give them opportunities to help their patients. So with that in mind, thank you for joining us. And Baco Diagnostics is sponsoring this Dean's Chat Learning Series. This is our second episode, so we appreciate you being kind of a guinea pig on it.
Oh, I'm honored to be here. And just from a disclosure standpoint, I am technically a consultant with Baco, so I just want to throw that out there. But everything I say today is evidence-based. Those of you who've heard me give lectures before, whether they're under FDA guidance, a promotional lecture, or they're a CME lecture, I don't care. I mean, I always follow the rules. I'm always compliant, but I always put in evidence. As you guys know, I run the course at Arizona College on evidence-based medicine and research. So it would be rather inappropriate for me to just spew stuff that was not evidence-based.
Absolutely. Joe, it was remiss of me not to introduce you. We're a team.
Well, thank you. I didn't even notice because I was all excited about this whole evidence-based approach. We're really excited about the opportunity to create something in addition to the kind of normal Dean's Chat podcast where we talk about professional career development and the amazing work that our community does. And this is a fun opportunity to talk about innovation and evidence-based approaches and how do we help our community thrive in their practice, not just survive. And there are so many things that we can, routes that we could go down. And so we appreciate Baco partnering with us in this. And I'm really excited actually to pick your brain on something that I have had the chance to talk with Dr. Shear and some of the on-site interviews that we've done about the Onico ID. I'd love to start with, in this realm of things like evidence-based approach and accurate diagnosis, what do you think is useful about this particular diagnostic test?
Well, the problem with onychomycosis, for as long as I've been involved with it, which is well over 30 years, has been diagnosing it. They throw out this number, in the dermatology literature, you always hear 50% of dystrophic nails are not fungal. There's something else. Well, what is that something else? Psoriasis, lichen planus, post-traumatic nail, brittle nail syndrome. There's a whole list of things that they throw out there. I've always kind of disagreed with this and felt that as podiatrists, we see more onychomycosis than anybody else. We certainly see more than dermatology. And I think podiatrists are capable of diagnosing onychomycosis probably 70+% of the time. However, that still leaves 25, 30% of the time where you have a dystrophic nail, you may think it's onycho, but in fact it's not. So how are you going to treat it? Because what we'll see is, we'll say, oh, this is onychomycosis, I'm going to give it an antifungal, but then the nail doesn't get any better, so the patient says, oh, that damn antifungal doesn't work. Well, maybe you just never made the diagnosis. When people are using oral antifungals like terbinafine, it's actually, listen, it's one of the safest drugs out there, gold standard for the treatment of onychomycosis, but it is right in the package insert that if you're going to use terbinafine, oral terbinafine, Lamisil, for a patient with onychomycosis, you should confirm the diagnosis before starting treatment. And I've seen malpractice cases where docs have not confirmed the diagnosis. They've had patients develop adverse events from the terbinafine, and then they sue the doc, and that's what they always go after. So I think it's important to confirm your diagnosis because that's going to help direct your treatment so that you can give appropriate treatment. And up to this point, we haven't really had great diagnostic modalities for onycho. Fungal culture, it's incredibly operator dependent. What do you get? Podiatrists in particular would send in just like distal nail clippings. Like that's my nail clipping symbology here. Distal nail clippings. Well, we know that that's not the best thing to send, and many of these would come back negative. You need to send subungual debris from the most proximal part of the nail, but that's fairly aggressive, and patients may not like that, and docs just sometimes don't do it. So they would send that in for a fungal culture. Fungal cultures, as they are only good about 50% of the time. Incredible amount of false negatives. And on top of that, it can take weeks for a fungal culture to grow. So then they went into some of the histochemical staining like PAS, GMS. Paper actually just came out about 3 months ago that looked at PAS versus GMS, and PAS is actually statistically significantly better than GMS. KOH, no podiatrist in the world does KOHs. The derms do. I mean, do you know a single podiatrist who kept their microscope after histology class back, 30 years ago? No, and now they don't even get microscopes. It's all done digitally. But the derms all have microscopes and they'll do KOH stains. We don't do that in the profession. So we were dependent on always sending these out to labs. A lot of it was garbage in, garbage out. You send a bad specimen, you're going to get a bad result. You're going to get false negatives. You're going to get false positives. And how do you know what you're doing with treating? So then PCR came out, polymerase chain reaction. Let's just put it all in the bucket of molecular diagnostics. All right. And it's been huge. It's been huge not only in the onycho world, it's been huge also in the wound diagnostic world, the diabetic foot infection world, and not only that, in medicine, sepsis, bacteremia, sepsis, that sort of thing. When you get a digital swab for MRSA carriage, that's all rapid diagnostics. And it's a great technique because it's incredibly rapid and incredibly sensitive. Here's the problem. In wounds, in ulcers, that sort of thing, where a lot of people are trying to use this, no good. There's just not a lot of evidence to support it. There is recently, actually in the last couple of weeks, there have been some incredible papers coming out on next-gen sequencing for osteomyelitis, which looks incredibly promising. But to this point, for wound diagnostics, still have a lot of people playing around with it. I don't like it. But where we do see an incredible amount of evidence is in the diagnosis of onychomycosis.
Is the wound stuff, because we had that little bit of a conversation, I don't know, one of those 4 podcasts that you were on, about that it amplifies whatever is there. And so when there are normal skin flora and other opportunistic organisms that are not necessarily pathogenic, is that really what your biggest concern is with diabetic wounds?
Yeah, absolutely. You're going to end up with, such a huge number of organisms. If you've ever seen a report from a lab that does next-gen sequencing, I'm not even talking about multiplex PCR or just, individual reagents against particular organisms like Staph aureus, whatever. You'll see 30, 40 organisms. You'll see fungus, you'll see bacteria, you'll see viruses even. We don't know what to do with any of that.
Yeah.
So it's really useless. But in onycho now, we have data that's really, really good. And hats off to the combination of Aditya Gupta. Now, I've known Aditya. He's a dermatologist out of Ontario. I've known Aditya for 20 plus years. He's got I think he's over 1,000 papers now in the area of onychomycosis and superficial mycoses as a rule. And Wayne Bakotic, who, of course, is medical director of Becker Diagnostics, they have published a series of papers on their technique for diagnosing onychomycosis and also looking for these new squalene epoxidase resistance genes that confer resistance to terbinafine. And the first paper that came out in like 2022, 2023, looked at 15,000 patients. Then the next paper they came out with, and I thought wow, that's mind-blowing, 15,000 specimens.
Yeah.
Well, when's the last time you've seen anything with 15,000 specimens in
Yeah.
it? Then they followed that up like 6 or 8 months later with a paper that had 60,000 specimens. Well, the most recent is 90,000 specimens.
Yeah.
So, and what they found is the combination now of the histochemical staining, the microscopic diagnosis using, let's say, PAS, along with PCR, just is an incredibly effective diagnostic modality. And you just get the best results, and they're very rapid, and you know what the organism is, and that helps direct treatment. And most importantly, is because of this new, it's called trichophyte indotiniae, or Trichophyte mentagrophytes subspecies indotiniae. You have this terbinafine resistant fungus that's out there now that has just been skyrocketing. In their first paper, 15,000, it was like 3%. Then it went up to like 5%. Now it's like 7 or 8%. So the numbers and the percentage of these resistant organisms is just skyrocketing, and they have the ability to look for that. So I think that's where this is so amazing, this ability to do this molecular testing in onychomycosis to confirm the diagnosis and look for the resistance genes.
Do you think some of that resistance, if we know that 50 to 60% of nail onychodystrophy is actually organism driven, and if we're just treating everyone, or again, there's a blanket statement, but if we're over treating with terbinafine, is that where you think we're seeing such an increase, much like we do with antibiotic resistance?
That's a great question, and I'm not sure that it is.
Okay.
I know a lot about this because, I remember, if you look at like the azoles have been around for over 50 years. The allylamines, like terbinafine, have been around for at least 30 plus years. I remember when terbinafine cream first came out, for tinea pedis. And I would get questions all the time. Well, Warren, with overuse of antifungals or people stopping and starting, aren't you concerned about resistance development? And you're absolutely right, Joe. In the bacteria world, that's dangerous. I mean, when you stop and start and you keep using different antibiotics inappropriately, that's why we have this whole principle of antimicrobial stewardship or antibiotic stewardship, which is the buzzword in infectious diseases and pharmacy, because you want to prevent resistance development. But we did not see that. So these drugs have been around 30, 40 years. We did not see resistance development despite widespread usage. You would get it in the lab. There were a couple of labs, Mahmoud Ghannoum, who's a PhD, another one of the top mycologists in the world, brilliant guy, also one of the nicest people you'd ever want to meet, and Dr. Gupta and others have, been able to create these resistant organisms in the lab, but they haven't been native. What you're seeing now is these organisms coming from other parts of the world. And the name Indotiniae, you're looking at India. In fact, most of our multi-drug resistant organisms we have, even in the bacteria world, have come from India. In the gram-negative bacteria world, MDR, multi-drug resistant organisms, there's an enzyme which is called the MDM that stands for New Delhi metallo-beta-lactamase. All right. And there are a couple of NDM enzymes now that confer resistance to gram negatives. Where were they first found? Delhi. Even MRSA, a lot of multi-drug resistant organisms started in India, and we're seeing that now even with fungus. And what you're getting is with international travel, people are just spreading this all over the world. There was a paper that was done that looked at this for Candida auris, which is a yeast that is multi-drug resistant to all known antifungals, that have found like there are four specific global strains of Candida auris, all are now found in the United States because there's just international travel. So I think that may be more of the cause of it. Now, is it why or how is it spreading more quickly? I don't know. I don't have a good answer for that, but I don't know that it's been overuse of antifungals as traditionally we would think of that with antibiotics.
Yeah, very interesting.
Mm.
Well, it is good that we've got a 24 to 48 hour turnaround on these PCR tests. I mean, it really helps the docs, helps the patients. To your point earlier about the old days, we'd wait for weeks, right?
Yeah. Yeah. So you can start the patient fairly quickly, or you give them a prescription. What I used to do, I'd here, so they didn't have to have a trip back. Here's the prescription for the terbinafine or the fenoconazole lacquer or the cycloperox lacquer or whatever. And I'll call you when the result comes back to tell you whether to start and whether to get it filled or not. Now the results are, 24, 48 hour results. They're very rapid. So the patient can start treatment, fairly quickly and hopefully get, better efficacy from it, because the stuff, it does spread, and it spreads within the toenail. It spreads from one toenail to another. It spreads from one patient to another.
Families.
Yeah, oh, absolutely. And, that's been my theme. Whenever I lecture on onychomycosis, my theme has been onychomycosis is an infectious disease. That's how I got into it, because of my ID background. Most people in onychomycosis and tinea pedis are into it because they're dermatologists. Almost all the publications in the world of onycho come from the dermatology world. Yet there's only really a handful even of dermatologists who care about onychomycosis, but they publish everything. We would write a paper on onycho. If I was working with one of the companies, they would send it to some dermatology journal. The dermatologists couldn't care less about this. They're too busy getting cash for putting in fillers. And, you go to the dermatologist, you're there for 5 minutes. And in that 5 minutes, they have biopsied or cut or frozen 10 different lesions on your body, right? And they bill for every one of them. You think they care about fungus? No, sorry, they don't. We do, right? We do. So, it's all been the dermatology world, but my theme has always been, this is an infectious disease. We don't think twice about treating a bacterial infection with an antibiotic. Why do we hesitate to treat a fungal infection with an antifungal? Instead, what has our profession done for the last millennia?
Empiric.
Yeah, 11721 or whatever, and that's why I said, I said this at a seminar this past weekend. Someone said, you really should copyright this term. Debridement is not treatment.
Yeah.
And I'll go one step further. Debridement is not treatment, and you can't get payment. All right.
And there's real risk for patients having these ridiculously dystrophic and aggressive nails.
Absolutely.
And when we think, so you and I have fun banter back and forth between the surgical and non-surgical parts of our community. And, certainly there was a period of my life where people would get referred to see me, and this was a legitimate concern for them. And my only tool in my toolbox was, well, I can take your toenail off, right? Like, I can put you on a medication, of course. But there wasn't the same diagnostic acuity. And what I appreciate so much, having then gone to a different world where when you're in a private practice situation, everything that walks in the door matters. It matters to our patients.
Oh.
And having that lens of looking at accurate diagnosis, a test that not only is 100% specific, but also has a really high sensitivity. This matters.
Sensitive. I mean,
yeah. And so can you help explain to my younger version of myself why I should have cared more in that moment?
It brings me back to, I remember I would always lecture. There's a CME company in our profession does residency training or residency seminars. And I would be in front of 100 residents. And I would say, how many of you can discuss or describe for me the Log-Hansen classification of ankle fractures? And I'm sure this was you, Jill. And And I say, okay, how many of you can describe the Zayas classification on onychomycosis? Not a single person raises their hand.
Cricket.
Yeah. Like, okay, so every one of you can describe a classification system for a condition you may, if you're in a hospital-based practice or a big group practice, you may see once a month. But none of you can give me the classification system that is used in every paper that is written in the field of onychomycosis, which is a condition you'll see multiple times a day. It's not sexy, it's not exciting, yet every week, and I teach our students this, you sign up for my NCBI through PubMed, and you can put down topics of interest. So every week you get every weekly, monthly, daily, whatever you want, every paper that's been published throughout the world in the scientific literature in that field. Every Monday, I get 3 papers, one on onychomycosis, one on osteomyelitis, and one on diabetic foot infections. Monday, so a couple of days ago, there were 4 papers on onychomycosis published, 1 paper on osteomyelitis published. Diabetic foot had like 6. Now, sometimes diabetic foot has 20, but the point is there is more science in this field than people think there is. And we need to teach our students that, we need to teach our residents that, because this does matter to the patients. You mentioned those big, thick nails, diabetes. We've all had what I call the click, click, squish syndrome, where you've had a patient with diabetes.
I know exactly what you're talking about.
Yep. Yep. Toenail click, toenail squish, and that pus comes out from underneath, and there's a.
I thought you meant the little abscess under the nail, because it's been putting so much pressure on there that it's ulcerated.
They're right, they're neuropathic, they don't feel it.
Yeah.
So it's squish, it's the abscess that comes out. So this is a condition that can spread. It does have major more medical morbidity, and maybe not so much mortality, but it does have medical morbidity. And it is an infectious disease. We should treat it. And as an infectious disease, you need good diagnostics. And that's what we have now with using like this OnychoID from Bacco Diagnostics, with that sensitivity, with that specificity, and with that rapidity. And I'd add one more thing in there, that this test actually has been certified through CMS. They call it MOLDX or MOLDX, Molecular Diagnostics. The MOLDX stands for Molecular Diagnostics. It is a criteria that the CMS has put out for approving testing for any molecular diagnostics. Again, we talked about bacteremias and sepsis and pneumonias. Any molecular diagnosis that's used in infectious diseases. That's what this MolDX actually approves. Right? Well, it now also looks at onychomycosis, and it approves tests for onychomycosis. And this OnychoID is actually MolDX certified. So, and that's approved in something like 28 states. So more than half the states in the United States accept that MolDX for their Medicare, as a Medicare carrier, as a test. Now, Bacco, big lab, can do that.
Yeah.
Here's where there's a problem. You see, once you guys get me started, I go. All right, here's where there's a problem.
Open the can.
All these podiatrists think they're going to set up a lab. Why? Labs for fun and profit. There's a company that I would get emails from, and I'm sure you've all gotten them, that says, we will set up a molecular diagnostic lab in your office. The benefits are endless. And what's the first benefit they mention?
Probably reimbursement. Yeah.
Increased practice revenue. All the way down at the bottom is like, increased, better patient outcomes, but increased. So people are signing up for that. And then they don't realize that a lot of their insurance carriers aren't going to pay for it. I just looked at this for the seminar I gave on Saturday, a couple of days ago. I did a Google search. Humana, United Healthcare, Medicare Advantage, both of them. A number of states will only cover molecular testing if not, they won't cover it for screening, they won't cover it for diagnosis. They will only cover it if the diagnosis has been made by a traditional method, like culture, histopath, whatever, and if the patient fails therapy. So these people are going to be setting up these labs and trying to bill for them, and they're going to get shot down. They're not going to get accepted. They're going to lose money. Then on top of that, we have the OIG, because I will tell you, I know this personally, not because I've done it, but because I've been talked to by the OIG and the DOJ. They are coming after docs who are doing their own testing. I was involved with one case with the DOJ where they had audio of a lab giving kickbacks to a podiatrist, and they had the rep from the lab on the phone telling the podiatrist he was on his way over with his payment.
Oh, jeez.
So our people, our profession is doing all this weird stuff. And listen, I'm all for making money. That's why I do the lecturing I do and all this stuff I do. But do it ethically, do it morally, and do it legally. You're going to find yourself in big trouble when you do this. And last thing, I'll shut up. I got a text message about 2 weeks ago from somebody I know, podiatrist, fairly well known. I won't go into anything that could identify him, but he's a principal in a large group. And he said they're trying to set up a molecular testing lab for onychomycosis because their money people are saying, why are we, giving this out to other people and they're making money? What about us? So they submitted that to their state Department of Health. State Department of Health came back and said, we're sorry, but the test that you want to use, which is a test that's frequently used, is not appropriate for a subspecies, speciation of trichophyton. They're not looking for antifungal resistance. So the guy's question to me was, is this real? I mean, is this nonsense from the Department of Health? So I'm not going to tell you. I called him and I said, yeah, it's real because we have this drug resistant fungus out there now. You need to look for it. And I also mentioned the DOJ. Well, we've got lawyers looking at that. Fine, I'm glad you got lawyers looking at that. That's not going to do you a lot of good when the DOJ comes calling. But the point is that why are you screwing around with, we're going to set up a lab in our office? Use a lab that has an approved test that are experts in doing this, and don't worry about it. Treat your patient. The money will come if you treat your patient. Now I'll shut up.
Well, that's why we enjoy working with Baco Diagnostics, Warren. I mean, they've done so much for our profession, from teaching students to residents to practitioners. To your story, Joe, when you were in private practice, yeah, you're a big-time surgeon, but this stuff comes in the door and you got to treat it. You got to identify it. You got to treat it appropriately. So kudos, and I agree with you 100%, Warren.
Oh, at least somebody does.
There you go. I mean,
I appreciate too the candidness of the discussion, Warren, because this is also really kind of where this whole new channel is coming from the Dean's Chat Learning Series, is how do we help support each other? Because I do take the lens that people are trying to do the best they can with the information that they've been given, but they're not given the full truth, or maybe there is a lot in the fine print that, yes, they should have read more carefully, but there's just a lot of moving parts. And so having people that are reliable, that you can hear why certain things matter. Why does a MolDX rating matter? Why does a diagnostic test with, the detailed analysis that I get, why does that matter? These are helpful for people that maybe don't have that information, that are wanting to know, how do I set myself up for success? What do I take on myself versus what do I outsource? So I appreciate your candidness. And I think that we should have more of these kinds of discussions with each other, because that is how we help each other grow in evidence-based clinical practice that supports quality patient care. And so you can come on your soapbox any day. I love to chat with you, and I love to kind of have our fun little banter back and forth, because again, you don't have to want to take this on. You could be the place that if it comes in your office, you could refer it to someone else. But where I will own my own discussion here, where my mistake was as an early practitioner was thinking that was just, you took the nail off or you just gave them a prescription. Like that was it. That was the treatment algorithm. And that wasn't accurate. That wasn't appropriate. And that was, again, I don't want to get myself in trouble saying these things, but my clinical acumen has changed at this point in my career, that we treat all of our different pathologies with high quality, evidence-based patient care. And again, that's where it's nice to have the support from our industry sponsors, such as Baco Diagnostics, that also wants that for their patients. And to your point, this isn't about making money. It's wonderful to make money for the work that you're doing, period.
Absolutely.
That's it, right? So again, I love your discussion. I don't want you to have to feel like you are alone in this quest for honesty and transparency. And you're allowed to have a strong opinion on things. You are an expert in this field, which is why we would love to have you back again as another, maybe fifth time person. We'll talk about something else at that point, just to make it fun. So
yeah, thank you. I appreciate that. And that's one thing nice about being in this profession for over 40 years now. I mean, I feel much more willing to say things. I mean, will I piss some people off? Maybe, but maybe it creates the people can be a little introspective if they're doing something. Again, absolutely be successful professionally. But it's when these people, when a rep comes up to you in a meeting or in your office, and the first words out of their mouth, and I don't care whether this is for diagnostic testing, whether it's for skin substitutes, and the problem with in the skin substitute world. I mean, in Arizona alone, we had that couple plead guilty to $1.2 billion in fraud for skin substitutes. And they weren't docs, they were running wound centers. But my point being that if somebody comes up to you at a meeting or in your office as a rep, and the first words out of your mouth are about their billing codes and how much money you can make, if you're in a meeting, turn and run away. If you're in the office, kick them the hell out. Because I'm sorry, I mean, yes, we should be making a living and we should be helping our patients, but there are right ways to do that and there are inappropriate ways to do that. And when we have the support and we have some of the corporate sponsors and the corporate partners who are supporting and can do this with us, why not use them?
I love your transparency also, Warren. There's that old saying, skill and knowledge defines permission. So you've got permission to state your opinion after 40 years,
I'm glad after all that opinion.
I love it. All right.
There'll be people who will, write nasty comments under the YouTube, but I won't look at them.
No.
We always do. And we just smile and say, thank you for listening. Thank you so much for showing up and listening all the way to the end of this to comment on it.
What's the other saying, Warren? In order to avoid criticism, do nothing, say nothing, be nothing.
I like that. That's deep. Thank you. I'll remember that.
Yeah.
It wasn't that deep. It was on the tip of my tongue. So.
Oh, okay.
All right. Any last words, Joe?
No, thank you so much, Warren, for your time again today and for being willing to have difficult conversations sometimes, or even just colorful conversations. And I love chatting with you. So until next time, my friend.
Thank you very much.
Thanks again, Warren. And to all of our listeners on Apple and Spotify, please give us a 5-star rating. And if you're watching on YouTube, and we've got a new YouTube channel, so we have to build from scratch, please, by all means, become a subscriber. And Joe and I will continue to bring leaders in the podiatric medicine and surgery field. Warren, it's just an honor and a privilege to have you back on the Dean's Chat Learning Series. And I look forward to round 2. Maybe we'll do something to you, like you said, about the new open access for our national journal. Maybe we'll get you and Dr. Tower on together.
Yeah, that would be great. We could talk antibiotics, you name it. You know what I like to talk about, and I'm always willing to come on Dean's Chat. And maybe by the 5th or 6th time, I'll even get a better mug.
Well, you're on 4, and a good one's going to be coming. We'll have to look into that, and we'll get back to you.
Okay.
All right. Cheers, everyone.
Thanks,
Bye-bye
guys.
Bye.
Yeah.
The information presented in this podcast is intended for educational and informational purposes only and is not a substitute for professional medical, legal, diagnostic, treatment, or documentation advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect those of their employers, institutions, or affiliated organizations. Listeners should not rely on the content of this podcast as medical guidance for specific health conditions. Always seek the advice of your physician or other qualified healthcare professional with any questions regarding a medical condition or treatment. Never disregard professional medical advice or delay seeking care because of something you've heard on this podcast. The hosts and producers of this podcast assume no responsibility for any errors or omissions in the content and are not liable for any outcomes related to the use of information discussed in the program. Thank you.